If your mouthwash and gum keep failing you, and you still get that stubborn, recurring taste or smell at the back of your throat, the culprit might be hiding where you rarely look, the tonsils. How to prevent tonsil stones is not just about removing something you can see, it's about stopping a cycle so the small pebble-like bits don't keep coming back. In a few minutes, I'll show you quick checks you can do at home, a focused 48-hour prevention initiation you can start immediately, and the realistic follow-up habits that lower the chance of stones returning. This is practical, clinician-framed advice. No scare tactics, no surgical first promises, just a stepwise plan to reduce the odds that tonsil stones become a recurring problem. Tonsil stones, or tonsilliths, form when debris, dead cells, mucus, food particles, and bacteria collect in the pits and crevices of the tonsils, become compacted, and calcify. They can cause a metallic or sulfur-like odor, a sensation of something lodged in the throat, or mild irritation. But before assuming the tonsils are the only source of bad breath, it's important to consider the most common alternatives. Not all halitosis is the same. The solution depends on the source. Many people first think tonsils, but often the main contributors are the tongue surface. A coating on the back of the tongue traps bacteria that produce volatile sulfur compounds, the molecules that smell like rotten eggs. Periodontal pockets around teeth where bacteria hide, especially when gums bleed or there's a history of gum disease. Dental restorations that aren't sealing well, trapping food and bacteria. Nasal or sinus drainage and postnasal drip, which bring mucus and inflammatory debris to the back of the throat. Less commonly, systemic conditions are certain medications that reduce saliva and change mouth chemistry. Because multiple reservoirs can coexist, preventing tonsil stones means addressing the tonsils and these other sites together when needed. The good news is that a few simple, evidence-framed self-checks can guide you to the right starting point. You can perform 3 short 60-second checks to help identify likely sources. Do them in a well-lit mirror and have a clean tissue or gauze and some floss on hand. These are triage steps. They don't replace a clinical exam, but they tell you where to focus your prevention efforts. First, the tongue scraper smell test. Gently extend your tongue and use a tongue scraper or the back of a wide spoon. From as far back as comfortable, make a few gentle forward strokes, rinsing the scraper between passes. Smell the residue on the scraper or the rinse water. If it has a strong sulfur or rotten egg odor, the tongue coating is likely a major contributor. This is common and often responds quickly to focused tongue hygiene and hydration. Second, the gauze or floss smell test for the teeth and gums. Wrap a clean piece of gauze around a finger or use a length of dental floss.
Wipe the spaces between a few teeth and smell the gauze or floss. If you notice a stronger odor here, or if you see blood during flossing, that points toward periodontal pockets or active gum inflammation as a key source. Periodontal issues usually take longer to resolve and often need professional cleaning and follow-up. Third, a visual tonsil inspection. Open wide, tilt your head back slightly, and look at the tonsils with a flashlight or good light. You might see small white to yellowish lumps lodged in the tonsil crypts, the pits. These can sometimes be seen without instruments. If you notice discrete, pebble-like spots that correspond with a bad taste or throat sensation, the tonsils are likely involved. If the tonsils look inflamed, swollen, or the throat is very red and painful, that's a reason to seek care sooner. A few important safety notes about these checks. Do not attempt to force anything out with sharp objects or poke deep into the tonsil tissue. Gentle inspection and smell tests are safe. Aggressive mechanical removal is not. If you feel pain, have significant bleeding, trouble breathing, or swallowing, stop and seek urgent evaluation. After the checks, you'll usually land in one of 3 starting categories: tongue dominant, periodontal or dental dominant, or tonsil dominant, though many people have overlapping causes. The next step is a short, targeted prevention trial that we'll call the 48-hour prevention initiation. Think of it as a focused experiment. Apply a simple set of measures consistently for 2 days to see whether symptoms improve. This provides rapid feedback about whether home care is likely to be sufficient or if escalation is needed. Before you start the 48-hour initiation, jot down a brief baseline, date and time, what you noticed, odor, taste, sensation, which of the 3 checks was positive, any recent changes in diet or medication, and whether you smoke or use alcohol regularly. This short log helps if you later decide to see a clinician. The 48-hour prevention initiation is intentionally conservative and safe. It targets the common mechanisms that promote tonsil stone formation, stagnant debris, low saliva flow, and bacterial overgrowth, without promoting long-term antiseptic overuse or harsh procedures. Begin with consistent tongue care. In the morning and evening, perform a gentle tongue scrape a few times, starting as far back on the tongue as you can without gagging and moving forward with light pressure. Rinse the scraper between passes and clean it after use. If scraping is uncomfortable, a soft bristled toothbrush can be used in the same manner. This reduces the bacterial load on the tongue surface, which in many people leads to noticeable improvement in days. Add warm saltwater gargles twice daily, once in the morning and once at night. Dissolve about half a teaspoon of salt in a cup of warm water, tilt your head back slightly, gargle gently for 15 to 30 seconds, and then spit.
Salt water helps loosen debris and has an anti-inflammatory effect. Avoid frequent aggressive gargling or very hot solutions. After meals, rinse your mouth with plain water and chew a piece of xylitol gum if tolerated. Xylitol stimulates saliva and reduces the growth environment for some cavity-causing bacteria. Stay well hydrated throughout the day. Dry mouth is a common facilitator of stone formation. Interdental cleaning is part of the 48-hour plan. Floss or use interdental brushes once daily in the evening. Focus on removing trapped food and reducing gum inflammation. If you notice blood during flossing, make a note. This is a signal to see a dental professional, but mild bleeding during improved cleaning is not uncommon at first. Use an alcohol-free mouthwash at night for a single short course during this initiation period. Alcohol-containing mouthwashes can dry the mouth, and with long-term use, worsen halitosis for some people. Limit antiseptic mouthwashes like chlorhexidine to clinician-directed short courses only. These are powerful agents with side effects when used long-term. If you wear removable oral appliances, night guards, retainers, or dentures, clean them daily with the cleaning method recommended by the manufacturer or your dentist. Microbial buildup on appliances can seed tonsillar crypts. Sleep hygiene matters. Elevate your head slightly if you sleep on your back, and use a humidifier if your bedroom air is dry. Reduced nasal breathing and mouth breathing at night increase drying and can promote debris accumulation. If you wake with a dry mouth or an accumulation of mucus, mention this in your lock. For nasal and sinus contributors, consider a saline nasal rinse once daily if you have symptoms of postnasal drip, nasal congestion, or chronic sinusitis. A saline irrigator can help clear mucus that travels to the throat. Do not use medicated nasal sprays without clinician guidance in the initiation phase. Stick to saline. Throughout the 48-hour trial, avoid heavy alcohol intake, reduce smoking or vaping, and temporarily limit foods with strong sulfurous odors, like large amounts of garlic or certain high-protein supplements, to see if symptoms change. If you're on medications that cause dry mouth, don't stop them, document them, and discuss with your prescriber later. Many medications are necessary. The goal is to track and communicate, not to self-adjust prescriptions. At the end of 48 hours, assess changes. If your tongue scraper residue smells much less, or if you feel the throat sensation reduce and the visible stones shrink or disappear on reinspection, that suggests conservative home care is making a meaningful difference. Many people notice improvement in this time frame when the dominant source is tongue calling or minor tonsillar debris. Keep logging what improves and what doesn't.
If you prefer a hands-on visual guide for safe tongue scraping, gentle gargling, and the floss gauze test, watch the linked hands-on demo where we show technique, tool cleaning, and common pitfalls. It will make the steps in the 48-hour initiation easier and safer. If this message is speaking to you, take 2 minutes to pause the video and watch the demo now, then come back and continue this plan. If the 48-hour trial reduces symptoms, the next step is a 2-week maintenance routine to consolidate gains and lower the risk of recurrence. This is where daily habits become the preventative barrier. The 2-week maintenance is structured into morning, midday, and evening blocks to make it practical to follow. In the morning, brush your teeth as usual with a fluoride toothpaste, then perform a gentle tongue scraping. Follow with a saltwater gargle or a short rinse with an alcohol-free mouthwash if recommended. Drink a glass of water to start saliva flow. If you use a nasal saline rinse and have symptoms of postnasal drip, do that in the morning as well. Midday habits are minimal but strategic. After lunch, rinse with water and chew xylitol gum for a few minutes if you tolerate it. The goal is to promote saliva and clear food debris. If you work in a dry environment or tend to breathe through your mouth, keep a bottle of water nearby and sip regularly. Small, frequent sips prevent prolonged dry spells in the mouth. Evening care is essential. Brush and floss before bed, clean any removable appliances, perform another round of gentle tongue scraping, and finish with a warm saltwater gargle. If you notice more phlegm or drainage in the evening, try a second saline nasal rinse. Sleep with a humidifier if your bedroom air is dry. If you snore loudly or wake gasping, note this and discuss with your clinician, as nighttime airway issues can affect mouth breathing and saliva flow. During the 2-week period, keep your logs simple. Mark daily whether you performed the morning and evening routine, whether you noted any change in smell or throat sensation, and any notable foods, alcohol, or meditation changes.
If you found any visually lodged in the tonsils, record the size and whether it changed after gargles or scraping. Some people will see sustained improvement within days and a clear reduction in tonsil stone formation within 1 to 2 weeks. If the origin of the odor was tongue coating, this is often the fastest to respond. If periodontal disease is significant, expect slower timelines. Professional scaling and a periodontist's plan may be necessary, and that can take weeks to months for full resolution. If nasal or sinus disease is a major factor, symptom control and topical nasal therapies managed by a primary care clinician or ENT may be required, and timelines vary. Let's consider a few typical cases to illustrate practical expectations.
Anna is a composite example. She's in her 30s, brushes daily, but rarely cleans her tongue, and after the 3 checks, found a strong smell on the tongue scraper, but minimal odor on the floss/gauze test and no obvious tonsil stones visually. She started the 48-hour initiation, twice daily tongue scraping, saltwater gargles, and xylitol gum. Within 3 days, she reported much less odor and a decreased chalky taste in the morning. For Anna, prevention focused on tongue hygiene and hydration solved most of the problem. Marcus represents a different pattern. He's in his 40s, has a history of bleeding gums, and a positive gauze smell test. He also noted some halitosis despite tongue scraping. Marcus began the 48-hour initiation, but because his floss test suggested periodontal pockets, he scheduled a dental visit. His dentist recommended a professional cleaning and a follow-up periodontal evaluation. For Marcus, the pathway to durable prevention included dental intervention and then a maintenance schedule. Improvements unfolded over several weeks rather than days. Leah is a composite ENT-focused case. She suffers from chronic sinus congestion and postnasal drip and occasionally notices small tonsil stones. Her tongue scraper test shows mild odor, and her visual tonsil inspection reveals a few small stones. During the 48-hour trial, she used saline nasal irrigation, increased hydration, and did the throat gargles. Her throat sensations reduced, but small stones persisted. For Leah, the combined management of nasal symptoms plus consistent oral routine reduced the frequency and size of stones, but she was advised to follow up with an ENT when conservative measures plateaued. These vignettes are typical cases, not prescriptions. They illustrate how different reservoirs respond on different timelines and why we tailor prevention based on the initial checks. If your checks point mainly toward the tongue, you're likely to see faster results with home care. If periodontal disease or dental restorations are implicated, plan for a longer resolution course and dental involvement. If sinus disease or chronic postnasal drip is present, address both nasal health and oral hygiene simultaneously. A few practical clarifications about tools and products. A simple plastic or metal tongue scraper is appropriate. Use it gently and clean it after each use. Alcohol-free mouthwashes are preferable for routine nightly use. Reserve stronger antiseptics for clinician-directed short courses. Xylitol gum can be helpful for saliva stimulation, but avoid sugary gum. Saline nasal rinses are useful when postnasal drip is suspected. Use clean water and follow device instructions to avoid contamination. Now let's look at common questions you might have as you begin these steps. Will scraping my tongue damage it? Not if you use light pressure, and stop if you feel pain. Does saltwater gargling remove stones?
It can loosen surface debris and help reduce inflammation, so small stones may dislodge or shrink with repeated gentle gargling. Larger impacted material may not fully clear with gargling alone. Should I use antiseptic mouthwash daily? Use alcohol-free, over-the-counter rinses for a short period if needed, but reserve stronger agents like chlorhexidine for clinician supervision because of side effects with long-term use. As you enter the second week of maintenance, you may notice patterns: stones that formed overnight, evenings with more mucus without obvious cause, or particular foods or supplements that seem to worsen symptoms. Document these and consider small, testable changes: cutting back on evening alcohol, shifting supplement timing, or improving appliance cleaning. Don't stop essential medications. Instead, record them and raise them with your clinician if dry mouth or other side effects seem relevant. During this phase, keep an eye out for specific warning signs. If your throat becomes severely painful, if you develop fever, trouble breathing or swallowing, a neck mass, persistent blood in saliva or sputum, or any rapid systemic symptoms, seek urgent care. These are red flags that require prompt clinical assessment rather than home prevention measures. If, after 2 weeks, you've made the recommended changes consistently but continue to have symptomatic stones, persistent bad breath, or visible tonsilitis that recur quickly, it's time to consider escalation. Escalation is not failure, it's a logical step to identify structural issues, chronic infections, or other contributors. The next conversation is where dental and ENT pathways diverge,
and where targeted clinical diagnostics, ranging from periodontal probing and dental radiographs to nasal endoscopy or throat examination, help to find longer-term solutions. We'll unpack those pathways in detail next, including concise scripts to bring to your clinician and what to expect from typical office evaluations. For now, focus on applying the 48-hour initiation thoroughly and maintaining the 2-week routine. Keep your log. Note what changed, what didn't, and any new symptoms. If you noticed immediate gains, reinforce the habits that produce them. If you didn't, prepare to bring your documented observations to a clinician who can help sort the overlapping causes and design a tailored plan. A final practical tip before we move forward. Avoid the temptation to poke or prod stones yourself with cotton swabs, bobby pins, or similar tools. People often feel tempted to remove something they can see, but aggressive mechanical extraction can injure the tonsil tissue, cause bleeding, infection, or make the problem worse. Gentle, conservative home measures and clinician-guided options are safer and more effective in the long run.
With these steps in place, the 3-minute self-checks, the focused 48-hour prevention initiation, and the 2-week maintenance habit, you've already taken the most important actions that reduce tonsil stone formation for many people. In the next section, we'll walk through what the dental and ENT evaluations look like when home care isn't sufficient, how clinicians document and coordinate care efficiently, what diagnostic tools they use and why, and how to decide collaboratively whether procedures like in-office removal, cryptolysis, or, as a last resort, surgical options are appropriate. We'll also provide short, clinician-ready scripts you can use when booking appointments, and examples of what to include in your log so your visit is as productive as possible. When home care doesn't fully solve the problem, clinical evaluation helps identify structural or medical contributors and prevents unnecessary guessing. Think of the clinician visit as the next step of the same investigation you began at home. The aim is to confirm which reservoir or combination of reservoirs is driving the stones, assess tissue health, and choose the least invasive, evidence-framed measures that will sustainably reduce recurrence. If your 2-week maintenance yielded only partial improvement, the most efficient next step is to take your log and present it to the appropriate clinician. Which clinician depends on your primary findings. If your gauze or floss test was strongly positive, or you have bleeding gums, loose teeth, or a history of gum disease, start with a dentist. If you have visible tonsillits that recur despite diligent oral and nasal care, or you have chronic postnasal drip, sinus symptoms, or obstructive throat complaints, see an ENT. If systemic signs are present, new unexplained weight change, excessive thirst, a fruity breath quality, or other systemic symptoms, book an appointment with your primary care clinician for medical evaluation and lab work as appropriate. These pathways are complementary. Sometimes you will be referred from one clinician to another as the evaluation proceeds. What will your dentist likely do? Expect a targeted oral exam focused beyond the obvious. The clinician will look for periodontal pockets using standard periodontal probing to check for deep spaces where bacteria and food can collect. They will inspect restorations, crowns, and bridges for margins that may trap debris. Bite relationships and hygiene around implants will be assessed. Dental radiographs may be ordered to evaluate bone level around teeth and to see if hidden decay is present. The dentist may perform a professional cleaning, scaling, and root planing if periodontal pockets are found, and then set a follow-up plan. If advanced periodontal disease is present, the dentist may coordinate with a periodontist for more intensive therapy.
Typical timelines here vary. Patients often notice reduced inflammatory bleeding and odor in a matter of weeks after professional cleaning and improved home care, but full resolution of deep periodontic pockets and their microbiological populations can take several weeks to months and often requires ongoing maintenance visits. What will an ENT do? The ENT evaluation adds an airway and throat perspective. The clinician will inspect the oropharynx and tonsils directly, often with good lighting or with a tongue depressor. In many clinics, a flexible nasopharyngoscope, a thin, flexible camera passed through the nose, will be used to look at the nasal passages, posterior choanae, and the back of the throat, to assess for nasal polyps, sinus drainage patterns, or anatomical factors that promote pooling of secretions. This endoscopic exam helps determine whether postnasal drip or anatomic narrowing is bringing mucus into contact with tonsillar crypts. If the ENT suspects deep tonsillar crypts as the primary reservoir, options include in-office removal of large superficial stones, office-based procedures to reduce crypt depth, cryptolysis, or in selected persistent cases, discussion of tonsillectomy. Imaging such as a CT scan of the sinuses may be ordered when chronic sinus disease or anatomic issues are suspected. Its purpose is to map sinus opacification, obstruction, or anatomic contributors to drainage, rather than to evaluate the tonsils per se. If an ENT performs removal in clinic, they will do so under direct visualization with adequate tools and local anesthesia as needed. This controlled approach avoids the dangers of home forceful extraction. What about PCP assessment? Your primary care clinician can evaluate systemic contributors that sometimes alter mouth chemistry and reduce saliva flow.
Typical triggers include metabolic states such as ketosis, poorly controlled diabetes, or chronic kidney or liver disease. Medication lists are also important. Many common medications cause dry mouth as a side effect and can indirectly promote stone formation. Your PCP will review your medications, order relevant blood work if systemic disease is suspected, and may coordinate care with dental or ENT colleagues. Again, do not stop any prescribed medication on your own. Document and discuss it with the prescriber. When clinicians evaluate you, good documentation from your side speeds decisions and yields better outcomes. Bring your log summarizing the 3 self-checks, what you did during the 48-hour initiation, and your 2-week maintenance notes. Include dates, approximate size or count of any visible stones, times of day symptoms worsen, and a short list of any new medications, supplements, or lifestyle changes. If safe and comfortable for you, a close-up photo taken in good light of the tonsil area can be helpful. Clinicians commonly use photos to triage or to plan in-office removal. Keep notes concise.
A short clinician-ready script you can read at the start of the appointment might be, I have a recurrent bad taste and occasional visible pebble-like bits in my tonsils. I did the 3 home checks, the tongue scraper smelled moderately, the floss test did not smell strongly, and I can see small white material in the left tonsil. I completed a 48-hour trial and 2 weeks of daily maintenance. Symptoms reduce slightly but recur. I'd like evaluation and to discuss next steps. This focused opening saves time and centers the visit on prevention and targeted intervention. For dental appointments, a useful script is, my flossing test showed strong odor and occasional bleeding. I followed a 2-week prevention routine but still have persistent bad breath and some food trapping under a crown on the lower left. Can you check for periodontal pockets and evaluate my restorations? For ENT appointments, a concise script is, I get recurring tonsil stones despite consistent hygiene. I use daily tongue scraping and saltwater gargles. I also have chronic postnasal drip. Can you examine my nasopharynx and tonsils to see if targeted ENT treatment or in-office removal is appropriate? For PCP visits, keep it short. I have persistent bad breath and dry mouth that hasn't improved with home care. I want to discuss possible medication side effects or systemic causes. Clinicians will typically document the history you provide and conduct targeted tests. Dental documentation will include probing depths, bleeding on probing, attachment levels, and any radiographic findings. ENT notes will record the size and location of visible tonsilloliths, findings on flexible endoscopy, and any sinus findings or nasal obstruction. PCP notes will summarize medication review and any laboratory results. This shared documentation helps clinicians coordinate care if referrals are needed. In terms of interventions beyond routine home care, the clinical spectrum ranges from minor in-office procedures to rarely surgery. In-office removal of superficial stones is often straightforward and provides immediate symptomatic relief. ENT specialists remove stones using controlled suctioning or blunt instruments under direct visualization. This is safer than home mechanical attempts because clinicians control the environment, use appropriate lighting, and can manage bleeding or discomfort promptly. In-office removal is most appropriate when individual stones are large, symptomatic, or persist despite conservative care. It is not preventive by itself. Unless underlying contributors are addressed, stones can recur. Cryptolysis is a clinician-performed procedure designed to reduce the depth of tonsillar crypts so that debris is less likely to become trapped. Techniques include cautery, laser ablation, or radiofrequency ablation, performed in clinic or outpatient settings, typically under local or light sedation.
These procedures reduce crypt depth and have been shown in some studies to lower recurrence rates of symptomatic tonsilliths while preserving most tonsillar function. As with any intervention, risks include pain, bleeding, infection, or incomplete effectiveness. Discuss with your ENT whether cryptolysis is appropriate for your pattern of recurrence. Tonsillectomy, the surgical removal of the tonsils, eliminates tonsillar crypts entirely and therefore removes tonsils as a potential reservoir. It is, however, a significant surgical procedure with an expected period of recovery and potential complications such as postoperative bleeding and pain. Tonsillectomy is typically reserved for people with very frequent symptomatic tonsilliths that impair quality of life, or for recurrent severe tonsillitis unresponsive to other measures. Surgical decisions are individualized, based on symptom severity, frequency, and the presence of other throat disease. If an ENT brings up tonsillectomy, expect a measured conversation about benefits, risks, and alternative options. Medical therapy can support other aspects of management. When sinus disease or postnasal drip is a major driver, the ENT or PCP may recommend targeted medical therapy for nasal inflammation or sinus infection. This may include topical nasal treatments or a course of medical management tailored to your condition. For significant periodontal disease, dentists or periodontists will design multi-visit professional care plans. For medication-induced dry mouth, clinicians may suggest saliva-stimulating measures, or in selected cases, prescription agents under medical supervision. Again, avoid starting or stopping systemic medications on your own. Discuss changes with your prescriber. A practical, evidence-framed timeline helps set expectations. If the dominant source is tongue coating, many people notice meaningful improvement within several days of consistent tongue scraping and hydration. Small tonsil stones sometimes shrink or dislodge with repeated gentle gargles and improved oral hygiene over days to a couple of weeks. Periodontal sources are slower. Professional cleaning reduces inflammation, often within days to weeks, but eradication of pathogenic pockets and stable reattachment typically unfolds over weeks to months with follow-up care. When ENT procedures are used, in-office removal gives immediate relief. Cryptolysis may reduce recurrence over months. Tonsillectomy removes the reservoir but requires a recovery period and is considered only after conservative measures and less invasive procedures have been tried. Throughout this pathway, safety and conservative practice remain central. Never attempt to tear recurrent stones by forceful home extractions. Avoid prolonged indiscriminate use of strong antiseptics. For saline nasal irrigation, use boiled, distilled, or appropriately filtered water and follow device instructions to avoid rare but serious infections.
For mouthwashes, prefer alcohol-free options for routine nightly use. Reserve stronger agents and chlorhexidine to clinician-directed short courses because of staining, caste alteration, and changes in oral flora with chronic use. Here are a few practical scenarios and how clinicians might respond, illustrating realistic outcomes. A patient who presents like Anna with a primarily tongue-based pattern and rapid home care response may be reassured, taught optimized tongue scraping technique, and scheduled for a routine dental exam. No invasive procedures are likely. A patient like Marcus, with clear periodontal involvement, will be offered scaling and possibly periodontal therapy. The expectation will be a multi-visit treatment plan and progressive improvement over weeks to months, with oral hygiene reinforcement and maintenance intervals. A patient like Leah, with mixed sinus and tonsil involvement, may receive concurrent ENT-directed nasal management plus a renewed oral hygiene regimen. If stones persist despite these combined measures, the ENT might propose in-office removal or cryptolysis as next steps. Weighing the costs and benefits of intervention is an important shared decision. In-office removal is low risk and can be done episodically for symptomatic relief. Cryptolysis offers a middle ground, aiming to reduce recurrence without full removal, but its effectiveness varies and depends on the degree of tonsillar crypting. Tonsillectomy provides definitive removal, but entails a recovery period and potential complications. The decision should follow a careful conversation that considers symptom impact on daily life, frequency of episodes, response to conservative measures, and personal preferences. A short clinician and patient documentation template can make appointments more efficient. For the patient, date of symptom onset, which of the 3 self-checks was positive, brief description of the smell or sensation, use a 0 to 10 scale for intensity, what you tried during the 48 hours and 2 weeks, any relevant medications or supplements started recently, and a few photos if available. For clinicians, a concise chart note might include symptom duration, prior self-care steps and response, physical findings, tonsil appearance, tongue coating, gingival status, probing depths, restorations of concern, endoscopic findings if performed, and the agreed plan with timelines and follow-up date. This shared clarity reduces repeated history taking and focuses visits on action. When counseling patients, clinicians should use clear, practical language that mirrors the prevention-focused approach you've practiced at home. Phrases like, "Let's address all potential reservoirs together," "We'll try the least invasive effective step first," and if this conservative approach plateaus, we'll consider targeted ENT options, give reassurance, and set realistic expectations.
For patients preparing to see a clinician, suggested questions to ask include, based on my log, which reservoir do you think is most likely? What are the least invasive next steps you recommend? If we consider a procedure, what are the expected benefits and recovery times? And what should I monitor or document at home to guide follow-up? A few additional evidence-framed prevention measures are worth emphasizing because they are low risk and often underused. Saliva stimulation is a simple, practical defense. Chewing sugar-free xylitol gum after meals, if you tolerate it and have no contraindications, stimulates saliva and can reduce bacterial adhesion to surfaces. Frequent sips of water, avoiding long periods of mouth dryness, and using a bedside humidifier in dry climates all help maintain a moist oral environment less favorable to debris accumulation. Appliance hygiene is key. Removable oral appliances should be cleaned daily and given time to dry between uses. Follow the manufacturer's guidance or your dentist's instructions for soak solutions and brush cleaning. Be mindful of dietary and supplement contributors. Very low carbohydrate or ketogenic diets can alter breath chemistry and sometimes produce a distinct fruity or acetone smell. High protein supplements and sulfur-rich foods may accentuate malodor for some people.
Rather than eliminating entire dietary patterns without reason, use your log to test whether changes correlate with symptom fluctuation, adjust servings or timing as a trial, and document effects. For those with dry mouth related to medications, practical non-prescription options include frequent sipping of water, sugar-free lozenges or gum, and using moisturizing mouth sprays designed for dry mouth. Your clinician can advise whether prescription agents are appropriate in your case. Remember that some saliva-stimulating products may not be suitable for everyone, so discuss them during your appointment. Addressing sleep-related factors can also reduce tonsil stone formation. Mouth breathing during sleep dries the oral cavity and promotes accumulation of debris. If you suspect sleep-disordered breathing, loud snoring, observed apneas, or excessive daytime sleepiness, mention this to a clinician. Managing nasal obstruction, optimizing sleep position, and treating contributory sleep disorders reduces mouth breathing and thus reduces one promoting factor for stone formation. Now, a few cautionary reminders about techniques you may hear discussed online. Home poking or digging with implements is unsafe. Sharp or improvised instruments can cause lacerations, intrude infection, and create bleeding that may complicate further management. Suction devices marketed for at-home use can appear attractive, but if they are non-medical grade or used improperly, they can injure delicate tissue. If you are considering any device beyond a simple tongue scraper or saline irrigator, consult a clinician first.
Likewise, chronic use of potent antiseptics is not a long-term solution. Chlorhexidine and similar agents can reduce pathogens in the short term, but long-term use leads to altered taste, staining, and disruption of the normal oral microbiome. Use these agents only when a clinician prescribes them for a finite course. Let's close this clinical section with a practical escalation algorithm to keep in mind. If your home checks point to tongue coating and the 48-hour initiation produces clear improvement, continue the 2-week maintenance and then adopt a sustainable routine. Gentle tongue scraping once or twice daily, adequate hydration, nightly flossing, and appliance care. If the positive finding was dental, floss, gauze smell, or bleeding gums, schedule a dental visit for probing and cleaning. Expect a multi-visit management plan and several weeks of improvement. If your checks point to persistent tonsillar material despite consistent home care, or you have recurrent symptomatic stones, seek ENT evaluation. If you experience systemic symptoms or medication-related dryness, consult your PCP. To make your appointment with any clinician as productive as possible, bring your concise log, a short description of which self-checks were positive, and any photos. Use the short patient script suggested earlier to open the visit efficiently. Ask about expected timelines and the least invasive next steps. If a clinician proposes an in-office procedure or surgery, request a clear description of expected benefits, recovery period, and alternative options. Shared decision-making yields better satisfaction and outcomes. Before we wrap up, a brief safety recap. Red flags that require urgent evaluation include fever, severe throat pain, difficulty breathing or swallowing, visible neck swelling, significant bleeding, or coughing up blood. If any of these occur, seek urgent or emergency care. For non-urgent but persistent problems, follow the triage sequence described. Dentist for dental periodontal signals, ENT for persistent or structural tonsillar and nasal contributors, and PCP for systemic concerns. Avoid forceful home removal and avoid prolonged, unsupervised use of strong antiseptics. Finally, let's bring everything together into a compact, clinician-framed checklist you can keep on your phone or fridge as you work through prevention. Use this checklist as a daily reminder and as a communication tool for appointments. Note which self-checks were positive, record whether you completed the morning and evening routine, list any notable foods, alcohol, or supplements that day, mark medication changes, and note symptom intensity on a simple 0 to 10 scale for taste or odor. If after 2 weeks you still note recurrent stones or persistent odor, bring this log to a clinician.
You've learned how tonsil stones form, how to quickly triage likely reservoirs, how to begin a safe 48-hour prevention initiation, and how to progress to a practical 2-week maintenance routine. You've seen when to escalate care and what to expect from dentists, ENTs, and primary care clinicians. You've also learned how to document and present your case so that appointments are efficient and focused on prevention rather than repeated history taking. If you haven't already, pause the video now to watch the hands-on demo that shows safe tongue scraping, saltwater gargling technique, and the floss gauze smell test. It clarifies tool handling, hygiene of devices, and common pitfalls. Then return to prepare your 2-day and 2-week logs. If at any point you notice red flag symptoms, or if persistent stones and breath issues remain after your 2-week prevention trial and appropriate dental treatment, schedule a clinician visit and bring your log and photos.
A focused clinical evaluation will help pinpoint remaining contributors and guide targeted interventions that balance safety, invasiveness, and effectiveness. You're taking the most important step by tracking, testing, and acting in a measured way. Prevention works best when it's consistent, evidence-framed, and complemented by timely clinical input when needed. Keep the routine simple, be patient with realistic timelines, and use professional guidance when conservative care plateaus. If this message helped you, consider keeping the 2-step record we discussed for the next 2 weeks, a short daily line for morning and evening routine completion, a 0 to 10 rating for odor and sensation, and a note of anything unusual. Bring that to your clinician when you book the visit. For resources, see the linked hands-on demo and the clinician scripts download to print or send ahead of your appointment. Take safety seriously, avoid aggressive home removal, and seek care when red flags or persistent problems arise. You've already done the most important work. You paid attention, you tested, and you started a prevention plan. Keep at it, and if you need clinical help, bring your log and ask for targeted evaluation. Preventing tonsil stones is a practical combination of routine habits, addressing coexisting dental or nasal contributors, and guided clinical care when necessary.